So I'm Emma Hallam, and I'm a consultant therapeutic radiographer based in Nottingham, and I developed and lead the Nottingham Radiotherapy and Chemotherapy Late Effects service. And today, obviously, you know what you tuned in to listen to is they're going to be about the late effects of pelvic cancer treatment. So we know that patients can go through a number of different types of treatments for cancer. And what we also know is that the more treatments that you have, you're more likely to have a higher symptom burden, so more side effects. And potentially there, you've also then got the potential increase for more risk of late effects. So we know that living a life with a history of cancer is unique for each person. Some patients will have very few problems or maybe very minor ones that will affect your day, not really affect day to day, but others will have a major effects which will be very difficult to live with. But for most, life is different after cancer, and there can be ongoing physical and emotional challenges that the patients will experience daily for the rest of their lives. And Macmillan did some work in 2013, and a quote from them was that cancer and its treatment often leaves a grueling physical and mental legacy for many years afterwards. So what is a late effect then? Well, a late effect is a side effect or a symptom that doesn't settle 6 months or can develop many years after treatment completion. It can often be difficult to diagnose, and it's also well known that treatment side effects, especially those from radiotherapy, can not only be difficult to diagnose, but that management can be really complex. And for some people, more damage can be done to the irradiated tissues by inappropriate investigations and treatment. So we know that at the minute there's currently about 3 million people living with cancer in the UK, and this is going to rise to over 3.5 million by 2025. And by 2030, this will be over 4 million people that will be potentially living with these potential side effects. We know that survival rates are increasing, and that's fantastic, but this also then means that there's more patients living with these long-term late effects. We also know that 1 in 4 cancer survivors will have 1 or more treatment-related consequences affecting their quality of life. Again, though, with varying levels, some it'll hardly bother at all, but others it can be really troublesome. And the Radiotherapy Trigger Project recognised that 1 to 5% of people will actually have severe symptoms needing a real multidisciplinary, so a multi-specialty approach. Joe's Cervical Cancer Trust did some research, and they found that 88% of cervical cancer patients had experienced at least 1 consequence, and only 10% had ever received any treatment for that. And then only half of the women who had experienced bowel and urinary problems had received any treatment. And those who'd experienced negative changes in their sex life, only 10% had received treatment. So it's really under-recognised and under-treated problems. Again, going back to Macmillan, they did some work in 2013 called Throwing Light on the Consequences of Cancer Treatment. And they found that 78% of patients had experienced a physical health problem in the last 12 months that was directly related to their treatment. And this is the one that I just found really staggering and really wanted to make me push on with our late effects service. And that was that 71% of those patients who'd finished 10 years ago or more had experienced a physical health problem in the last year, again, directly related to their treatment. Found that 40% were living with emotional problems and hadn't sought any help, and that 40% said they were unaware of any long-term side effects. Now, I also know that when I used to sit in clinic with patients and consent them for treatment, that often patients will take anything at that consent process because they just want to survive the cancer. I also know that back in the day, we were quite poor really at telling patients about the long-term effects of treatment and what possibly could happen. I think we're much better at it now. And the Royal College of Radiologists have just developed some fantastic consent forms that really do go into the level of risk and potential late effects. So the more departments get on board with that for treatment, particularly for radiotherapy, the more people and patients will be aware of the long-term effects. The problem we have, though, when is a late effect not a late effect? And that's, correct diagnosis is so important, because we know that 3.2 million people over the age of 65 will suffer with urinary incontinence. A majority of them are women. So how do we know when patients come to clinic that they didn't have it before, that they didn't have a problem before? And it's amazing how patients forget what life was like before cancer, and everything then focuses on this. So it's really important that we're getting good baseline data, and by that we mean that we're finding out what a patient was like, what their history was like before we even start any of these cancer treatments. So the thing with pelvic late effects is that they really can be life-changing. We often see patients and they talk about feeling tied to the toilet or not being able to leave the house. I had one patient who actually had a toilet put in the back of his van. He bought a little, like what I call the red postman pat vans, and he had a toilet built in the back of that because he could not be that far away from the toilet. I have patients who used to play golf, they just can't go and play golf now, and certainly patients who have had to give up their job because they just feel that they cannot leave the house because they want to be that close to the toilet. They often say to me that nobody told me about this afterwards. With pelvic late effects, we affect quality of life in so many ways. It can be embarrassing for some, it can be a really isolating. It affects relationships, not just our intimate relationships, but people not wanting to go out and socialise with their friends anymore. And it affects the abilities for us to work. So I'm going to particularly focus today on radiotherapy and chemotherapy, but with radiotherapy, it really is that treatment that keeps on giving. And this is because of something called radiation-induced fibrosis. And this is something that's completely unavoidable. It's a progressive fibrotic sclerosis with varying clinical symptoms, and it can affect all the soft tissues that are in that radiotherapy treatment field, including skin, connective tissue, muscles, nerves, and blood vessels. And what it does is it affects the normal body functioning by causing hardening, tightening, and restriction of tissues and muscles. So it affects how that part of the body works. So if you think about the pelvis and how our bowels work and how our bladders work, you know, it is no surprise really that patients can experience these level of late effects. It sadly can be lifelong, and it's a progressive disorder. Now, with pelvic late effects, it's also known as pelvic radiation disease, and this is where patients will have one or more ongoing symptoms of variable complexity that affect people who've had pelvic radiotherapy. It can include cancers of the colon, rectum, anus, prostate, testes, bladder, cervix, and womb, but also those patients who may have had total body radiotherapy and radiotherapy in the pelvic area for primary and even secondary cancers. And it affects the bladder, bowel, sexual organs, stomach and digestion, skin, bone, nerves, nerve supply, lymphatic system, and mental health. The one thing to say, though, is that there is an amazing charity called the Pelvic Radiation Disease Association, and they've been tirelessly working for years to try and get the awareness of pelvic radiation disease out there, and they're an amazing support system and service for anybody who has this. When I started our late effects service in 2013, we had no guidance whatsoever, but I'm really proud to say now that Pelvic Radiation Disease Association got lots of real experts in the field, and I was really privileged to be a part of this. And we've now produced the Pelvic Radiation Disease Association Best Practice Guidance. And this is absolutely everything that you ever need to know about pelvic radiation disease, not just the physical, but the psychological and psychosocial side of it as well. So it really is an amazing document, and it can be found on the Pelvic Radiation Disease Association website. And I could actually stop my talk here and just signpost everybody to this, because it really is. It's got everything from what the actual best practice, that gold standard, if you had access, money was no object to any services out there, this is what you would do for a patient to help them. But it's also got lots of tips and tricks that health professionals can use, and patients themselves, if they haven't got access to late effects services and that kind of thing. So what I want to move on to now is the radiotherapy late effects that I commonly see in our clinic. I just thought we'd talk through that in a bit more detail. So first of all, it's the things that affect the bowel. So that'll be diarrhea and constipation, and often this urgency and not being able to hold, so this incontinence that patients get. Like I say, they often feel that they just cannot, you know, if they feel the need to go, that's it, they need to be on that toilet, otherwise they're going to be in a mess. Straining, where patients just literally cannot feel like they're emptying their bowels, or they constantly feel like they need to empty their bowels. They never feel like they've quite finished. Patients can experience rectal bleeding. This can be because of the damage that's been done around that area, but also because of the straining that patients can put them through, or their stool may be too hard. We can have malabsorption. This is where we're in the inability to reabsorb the nutrients that we need, and this can lead to malnutrition and also poor appetite as well. Radiotherapy can affect the gut microbiome. So we all know all about these healthy gut bacteria we have now. Well, radiotherapy just destroys all of that. So, you know, patients will often become undernourished in certain minerals and vitamins, but also it will lead to things such as diarrhea and that kind of thing as well. Some patients will experience excessive wind, but also foul smelling wind as well, which can be really quite prominent. Some patients will recognise that they've got an oily stool, so when they look in the bowl afterwards, they may see this, like the water's got like an oily film on top of it. And I've already mentioned the urgency and the incontinence. And all these things can be signposts really and signals that there's something much deeper going on. For some patients it isn't, but for others it is. It may be that we've got some kind of bile acid malabsorption going on, or some exocrine pancreatic insufficiency, or some small intestinal bacterial overgrowth. But this is really high level stuff which would need diagnosing by an actual specialist. In terms of bladder, again, we get patients who have this incontinence and this urgency to go, so they can't hold it, or they're constantly leaking. And this change in flow, where they just feel that, you know, men have to then sit down sometimes because it just ends up everywhere, or their flow is so weak that they're not feeling like they're emptying their bladder all the time. Radiation cystitis, this burning when they go, and can be because you're constantly feeling like you need to go. Repeat infections, and again, bleeding. In terms of the bone and skin, it can be changes to the skin in the area that we've given the treatment to, but also pain. And this can often be related to something called pelvic insufficiency sacral fractures, which are really tiny hairline cracks that can happen in the pelvis area. In terms of sexual function, radiotherapy can cause erectile dysfunction for the men, or the inability to get an erection or maintain an erection, or it might be that you can't ejaculate anymore. And for females, it can be this vaginal stenosis. So this basically where they feel that the vagina shortens, and you get lots of fibrotic tissue in there. It can be very painful, and dryness as well. In terms of menopausal symptoms, we have hot flushes and mood changes, and again this vaginal dryness, which can be really painful for some ladies if it goes untreated. We've seen infertility. Pain is another big one, and it's not just from any insufficiency fractures or things with the skin. It can be because of the bowel and the bladder, you know. But also we tend to find patients often can come with reduced mobility, and that's not just because maybe they've got an insufficiency fracture, but it can be because of the discomfort they've got in their tummies really. And all of these come in line with sleep disturbance, because patients will say they're getting up 5, 6, 7, 10 times a night, or can't get back to sleep. So some of the things that we less commonly see, and this is just in my experience that we less commonly see, I know other services may see lots of patients with lymphedema, but we're talking about lymphodemas. This is where we see swelling in the legs, but it's not just in the lower limbs that we see, it's also around the pubic bone. So it's really important that if you notice any swelling from your waist down, basically, really, that you are reporting this, because it may be this some damage has been done by the radiotherapy, or indeed surgery if you've had surgery. And we know that with lymphedema, the earlier that we can diagnose it, the earlier we can treat it. Sometimes the more manageable it is, but again, it often is a lifelong progressive condition. Nerve damage, and this happens is also known as radiation-induced lumbosacral plexopathy, and this can be really difficult to diagnose, and often patients go round the houses lots before they get a diagnosis of this. But often it can be characterised by patients not only being in pain, but by not having the ability of the strength in their lower legs. When they try and push themselves up out of a chair, they find this really difficult, or their legs give way on them. So fistulas, this is where you basically you get holes in your back passage or in your vaginal wall, and these can become infected. Necrotic ulcers, I've put it on the less common side, but we have seen quite a few actually in our clinic. And this is just either where the skin hasn't healed in the treatment area, and it can particularly happen around the vulva, or around the perineum, around your back passage, or it's something that's developed like I say, these years later due to this radiation dermatitis. And as always with radiotherapy, there's always that risk of secondary cancers. In terms of chemotherapy then, we know that chemotherapy is a systemic treatment, and yes, we know that certain drugs do cause certain specific side effects, but on the whole, chemotherapy affects anything within the body really. So what do we see then in our clinic? Well, mainly it's gastrointestinal problems, so those problems with the bowel really, or also sometimes in the esophagus, the upper GI system, gastrointestinal system, that we see. And it's exactly the same as what we've talked about for the radiotherapy. Peripheral neuropathy, which is also known as pain, which is where you get tingling of the hands and feet. Often under-recognised really and under-treated. I think it's often quite dismissed during treatment, but this can be really problematic for some patients if they can't manage to get themselves dressed anymore, they can't do any fine movements with their hands. So it's really important that we're trying to recognise this. It is quite hard to treat, but again, we can give certain aids and exercises that may help patients to live better with. Fatigue is a common one, menopausal symptoms, and this memory loss and cognitive function is actually, I would say it's actually on the rise, or certainly patients are coming forward with it more now. It's just ability that they can't remember things. I've got patients who can't remember to turn off the cooker when they've been cooking. But it's really about trying to work on those skills and tips and tricks on how to live with these side effects. The ones that we less commonly see in our clinic is fertility issues, cardiovascular disease, and osteoporosis from the chemotherapy. So what we need to remember though is that all of these cancer treatments come with lots of other effects as well that are not the physical effects of treatment. And the big one is fatigue. And we really know that with fatigue, it can affect everything. And the more side effects that you've got, so the more symptoms that you might have, the more chance you've got of feeling fatigue. Can I just ask if there's one on mute, because I can hear somebody in the background. I don't think they can hear me, can they? Okay, I'll carry on. And pain, obviously, again, if you're in pain, this affects everything. It affects your sleeping. The one thing I would like to say as well about fatigue and pain is that these is varying levels, and we really need to be thinking about how it's affecting you as a person. It's about what matters to you. I'll have some consultants and other health professionals that won't have referred a patient to my service, and that's because they haven't deemed that as being significant enough. You know, they'll tend to refer a patient if they're getting up for a wee 6 or 7 times a night. But that one person who's getting up once, they won't bother, but they've not actually asked if that patient's bothered by it. And I've had a patient who's actually lost his job because he was getting up in the middle of the night, about 3 o'clock, needing to go for a wee, and then could not get back to sleep. So he was so fatigued, he had to give up his job. And that's really significant to him. But looking at level of toxicity, another person who gets up 8 times a night would think, well, that's nothing getting up once. It's really important that we're looking at patients and your subjective bother and what matters to you. I've already mentioned about the cognitive function, but also this functional impairment, when you just feel that you just cannot work or do the things that you used to be able to do before. Body image concerns can be really significant for some. So it could be because of lymphedema, it could be because somebody's got a stoma now. But not only is it about what changes in the body function, in our body image, but it's how we are sexually anymore. We get such changes in sexual function, and relationships can break down. We have lots of people who don't sleep in the same bed anymore because one's getting up in the night so many times, don't want to wake the other one. We really can wreck relationships and social changes. We need to think about the psychological challenges that patients go through. So it's not always about thinking about fear of recurrence, but we have a number of patients who've got what we call survivor's guilt. And these are people who feel like they should feel grateful really and happy to be alive, but actually they don't feel it because they're living with such effects from their treatment. Some patients also will say, well, they told me I'd be getting up in the night for a wee, or they told me I might have some bleeding from my back passage, so I should be grateful really. Some of the patients also stop telling their family and friends because they're just sick of telling them the same thing because they don't feel there's anything ever's going to change for them. So this, if you can think about it, if you've got a physical effect and you've got all these psychological effects as well, it's no wonder that with pelvic radiation disease and pelvic issues that patients really can feel that they've got a much lower quality of life. And we know that sometimes patients have difficulty in adjusting to this, what we call new way of life. And also, like we said, we have educational and vocational challenges where either people can't go back to university or having to change their job or indeed lose their job because of the effects that they've had from their treatments. So what I want to move on to now is try and give you some tips really on living with late effects. So first thing I would say is to make sure that you're moisturising your skin well. And that's because radiotherapy has the tendency to dry everything out. And we know that the more hydrated the skin is, the more supple it is, and that certainly helps anybody who's got any lymphedema. So it's really good practice to keep moisturising. Pelvic floor exercise and toileting exercise is something that I'm going to come on to on another slide, but just movement in general is really important. And that's, you know, I mean, I'm telling you that, and you're on this part of on the move against cancer. So I'm sure you know how important that is for everything, but certainly we know it's the single most important thing you can help with fatigue, but also with the majority of the late effects that you may experience. Staying hydrated is important, and also trying to manage a balanced diet and maintaining a healthy weight. We know that people who've got some of these late effects, particularly lymphedema and pain, the less weight we're carrying around really can be beneficial. Get any signs of edema or swelling checked, and also any changes in your bowel or bladder function checked, because it's really important. Even if you think, oh, well, you know, I listened to that and they said it was a late effect, it really does need checking out first by a health professional. Mindful and relaxed breathing, abdominal breathing, really can help with pain. We know that the more relaxed we are, the more that we're breathing from our abdominal, so our deep belly breathing rather than our chest breathing, really can help to lower anxiety, but also help, like I say, with those pains that we may be experiencing. And, you know, it might be worth just asking for seeing your GP, see if they can give you some routine bloods or to check for some vitamin deficiencies, because of the fact that what can happen if your bowel's not working correctly. So there's a little bit more detail then. So I'm not going to sit here tonight and tell people to reduce the fibre in their diet, or, you know, to take out dairy or anything like that, because it really does need to be trained, preferably a dietitian, if you have access to a dietitian who would do this. But so I just thought I'd give some little tips that you might want to do if you haven't got access to a late effects service. So first thing really is, it's good to try and keep a food and symptom diary. So, I mean, I had a quick look today, and we've got one that we designed, but, you know, there's loads on the internet if you want to have a look. Even NHS website, even NHS Direct has got a food and symptom diary on there. And there's something called the Bristol stool chart, which basically shows you what your poo looks like, basically. And what you might want to do is write down every time you have something to eat or have a drink or some medication, and see what the symptom is. What was the reaction to that? Was there a time associated with that? And what did that stool look like? So you just write down type 1 or type 5. And do this for but I'd do it for about 5 days. So we get our patients, anybody who's coming to clinic, we ask them to do this for 5 days, and we ask them to, every single thing that passes a patient's lips, to write them down. And then you could take this, you might look at it then and think, oh, well, look, every time I've had something that's really high in fibre, so every time I've had fruit or anything like, look, I get raging diarrhea half an hour later. So it might be that there's a link there that you can then go and then speak to your GP in the first instance, maybe if you haven't got a specialist team to go and speak to. But we know that patients, if they eliminate caffeine, we know caffeine can be a real irritant on the bladder and on the bowel. So that's one of the first things that we ask patients to do, is to cut out caffeine, but also artificial sweeteners. The artificial sweeteners are really can play havoc with bowels. So that, and as well as fizzy drinks, can help, particularly if you're experiencing lots of wind. You might want to reduce fatty foods for a little while, just to see, so in those high processed fatty foods, and just see if that makes a difference. Try eating small regular meals, particularly if you find that you've got lots of bowel problems, in particular diarrhea. You might find that actually eating smaller meals will actually stop your food racing through your bowel. So eating regular meals. It's amazing also as well the difference it will make if you start eating your meals at a table rather than slumped in front of the TV, and that can really help with your digestion. And then I want to move on to pelvic floor exercises. So this is something that we ask all our patients to do, and so we teach it them, and we keep going back to them as well, giving them support for this. Some places will have a pelvic floor physio, which is fantastic if you have, and they can offer some really good support in this area. But we know that the pelvic floor muscles play such an important role within this. So not only do they support our organs and give us core support, but they also help with our sphincter. So they help with the bowel and when your poo needs to come out. But it helps with circulation, and it also helps with sexual function as well. So I haven't put any pelvic floor on here because there's a number of ways that you can do them, but they're all over the internet if you search them. I know for a fact that Prada have got some on there, Prostate UK have, the Joe's Cancer Trust, there's so many of them are out there, and also NHS has also got some on there as well. The other thing to think about as well, though, is if you're experiencing some sexual difficulties, particularly for the ladies, it could be actually that you need to relax your pelvic floor. So it goes a bit against what we always say about doing pelvic floor muscles, but it really is important that you might want to have a look at that. That relaxating the pelvic floor muscles if you're having a problem with having sexual intercourse. The other thing is you might want to look at something called the Squeezy app, and that is an app that you can download, and that helps you to remind you to do your pelvic floor exercises as well. And then what we also know is that we very rarely in this country sit on the toilet as we should do. When we sit, as you can see there, the orange person, as we sit on a toilet as we do in the UK, actually what we do here is we actually block the intestine by pinching. It pinches the pipe at the base, really, so to speak. Whereas if we was to get a stool for our stool and raise our feet off the floor by about a foot and kind of lean forward in this brace position, it really does open up the sphincter area, and essentially your stool should just literally slide out. There's an excellent thing on YouTube called Squatty Potty, if you wanted to have a look at that, and it's a unicorn squirting out ice cream out of his bottom, but it does show you about if your legs are raised, your knees are raised, that it does actually release the muscles in that area. So where else can you find help then? Well, the first thing is just to say, particularly with pelvic late effects, is that report anything that doesn't feel right, any changes. That's really important. And this might be that it's with your GP, and it might be that you go with your GP and you say, I'm wondering if I've got this pelvic radiation disease, or I've had radiotherapy, or I've had chemotherapy, and take the guidelines along with you. It may be that your GP hasn't seen the best practice pelvic radiation guidelines. So it really is important that you can take that to them and have that conversation. But if you have got access to a local late effects service, then go and see them. So in Nottingham, we can see anybody who was either treated in Nottingham or is under a Nottingham or Nottinghamshire GP. And also, try contacting the team where you had your treatment, because there are so many fantastic late effects services that are setting up now that are being led by therapeutic radiographers, and they're doing amazing work. So we really are pushing forward with this now, because we're recognising as a profession how many patients are being affected by this. There's also other services that are run by specialist nurses and gastroenterologists. So just starting where you had your treatment might be a really good place to start. Maggie's centres are always good for a bit of help and support, and also I know ours is, and then I think another one down south is doing some support groups for patients who've got pelvic radiation disease. And again, like I said already, the fantastic Pelvic Radiation Disease Association really can be. They run an online support group, as well as all the information they've got there. They do a toilet access card. They also do an out and about toolkit, which has got a radar key. It's got wipes in there. It's got all sorts of things that you might need. So it's really good to get contact them and join up. You can try speaking to your GP, like I've said, but also if you feel that you need some physiotherapy for any of these symptoms, or you feel that you have got swelling and might want to be referred to lymphedema, they can refer direct to them service. You don't need to have got a diagnosis of pelvic radiation disease first. And then some other helpful websites. So Macmillan Cancer Support's got lots of information on there. I've already mentioned about Pelvic Radiation Disease Association. Prostate Cancer UK, particularly great for, like I said, the pelvic floor exercises. Joe's Cancer Trust, Cancer Research UK. Then we've got TrekStop, which is the support charity that supports patients who are treated in their 20s and 30s. And then if you're struggling with any lymphedema, then the Lymphedema Support Network and the British Lymphedema Society have got some really good videos on there and YouTube links that can help. Joe Divine is a service. It's not a service. It's a company, but it's also a website which sells lots and lots of devices to help with sexual dysfunction, lots of lubricants. And things, but what's great about this is that it's actually been set up by a nurse, or an ex-nurse, Sam Evans, and she's amazing. And there's lots of blogs on there that she's got. She really does understand about menopausal symptoms, about sexual dysfunction, both for men and for women. So it really can be a good place to start if you don't feel you maybe want to speak to a health professional about it. And of course, the Move Against Cancer, which we're on today, has got some really good information on there, particularly about movement and fatigue and things. So just things to be mindful of then is that, you know, we all go through the same stuff but differently. So, you know, don't let anybody tell you that it's not what to expect. It's not significant enough. It's about how you feel about it, and that's what's really important. Thank you. That's the end of my presentation, and I'll take any questions.